Good afternoon, Director Board, Department Leader, and all of my colleagues. I'm Dr. Tín from ICU Department. I'm deeply honored to be here today to discuss advancement in critical care. The goal of presentation will be explore some recent advancement in critical care. The content of today's presentation will consist of four main parts as follows. The first part, why should we discuss this topic? Why should we care? What will we discuss today? And conclusion. Let's begin with the first part, the reason for updating knowledge. So, why should we care about new advancement in ICU? We all know that the ICU patients have life-threatening conditions, so the high mortality rate. In the race of death, the ICU doctor need to be stronger, and new knowledge, it means new weapon for ICU doctor. Andrew and the college conduct a research about diagnosis error in ICU, showing that this race is quite common and negatively impact patient outcome in the ICU. So, more knowledge will bring additional skill in patient approach and clinical care, thereby reducing the rate of diagnosis errors. Moving on to the second question, what aspects should we care about? Aspects to be cared about in the ICU often revolve around issues such as initial stability, diagnosis, treatment, and monitoring. Common severe abnormality in CAR include severe hypoxia, respiratory failure, ARDS, shock, multi-organ failure, and cardiac arrest. We often need to update two main aspects, guideline and technique. Due to the time constraint in this presentation, we'll briefly cover the five main topics as ARDS, cardiogenic shock, CRRT, POCUS, and AI in the ICU. So next we will divert into each specific topic. The first topic is ARDS. We all know that ARDS is a life-threatening acute respiratory failure condition that requires timely diagnosis and management. It was first mentioned in 1967, but it was until 2012 that the world officially reached consensus with the Berlin 2012 definition for ARDS. However, in recent years, especially after the COVID-19 pandemic, when ARDS become more common, the old definition needs some adjustment. So in 2023, 12 ARDS experts from around the world gathered and proposed a new consensus on ARDS diagnosis standards that are more practical. So what does that mean? The main point is to accept lung ultrasound, a new technique in the ICU as a diagnosis tool, and also use SpO2 per FiO2, meaning no need for arterial blood gas, and HFNO is mean not require mechanical ventilation for diagnosis ARDS. In summary, these new contents make assessing ARDS is more practical. This is an example image of typical lung ultrasound feature of ARDS with bilateral B-line consolidation and irregular pleural line. You guys can see here is B-line, pleural line irregular, and subpleural consolidation here. After briefly discussing diagnosis, we cannot overlook the treatment aspect of ARDS. Here an overview of ARDS treatment with foundation in lung protective, ventilation strategy, medication use, and VV ECMO. The American Thoracic Society ATS issued updated evidence-based treatment guidelines for ARDS, including some new recommendations. use of systemic corticosteroid, BVND, neuromuscular blocker, higher Bs, they against prolonged lung recruitment maneuvers. After discuss about ARDS moving from the lung, now we come to the heart. We will move on to another important topic, cardiogenic shock. The SCI classification of cardiogenic shock developed by the American College of Cardiology Interventional Culture and American Heart Association is increasingly being applied. There are 5 levels of cardiogenic shock. A is mean at risk, B mean beginning, C is mean classic, the patient have the symptom of classic shock, D mean deteriorating, this means the patient have the shock, they still in the condition of hypoperfusion. The finally is ischemic. Ischemic means the patient have a severe life-threatening condition like cardiac arrest. Specific criteria for each group are detailed in the full text article. So the mortality rate at the each level is here. You guys can see that a patient with the higher level of sky shock have higher mortality rate. In the ischemic level, the patient can have the 19% of mortality rate. With this classification, we can give a conclusion. Maybe we think about trying to keep continue, or we can think about give up. SCI is helpful in providing insight that cardiogenic shock is a dynamic process that can change from one state to another, either worsening or gradually recover. Clear identification of these stages help us make appropriate intervention. In the most severe case of cardiogenic shock, we often need to use mechanical support devices for the heart. These are the products currently available on the market: IABB, and ECMO and impeller. ECMO, we have the VA ECMO, we have the impeller, and we have the tandem heart. We was familiar with IABB and VA ECMO. IABB and ECMO are well known to intensive care physicians, and pro techniques have been implemented in our hospital for a long time. ECMO still a life-saving treatment. ECMO is still a life-saving treatment in severe cardiogenic shock or refractory ARDS situation. ECMO technique continue to evolve and hold much promise. Hybrid ECMO and parallel ECMO in some special cases. Two newer techniques are impeller and tandem heart. In impeller, a pigtail catheter is inserted into the left ventricle through a femoral artery, which will have a blood suction machine from the left ventricle and pump it into the aorta. In tandem heart, a cannula will go from the femoral vein into the right atrium and then pass through the left atrium, then suck blood out and pump it into the nearby artery, similar to ECMO, but without the risk of left heart overload in comparison with VA ECMO.
The impella
This
is the
video
world's smallest heart
illustrating the
pump.
impeller
The
technique.
cardiologist
We
places the
insert a
impella heart
catheter
pump
in the
into position
femoral
using standard cardiac
artery
catheterization
and come
techniques,
to the
inserting the
aorta
catheter into the leg artery and guiding it
here
into the
and
heart.
come to the left
Once in
ventricle,
place, the impella
and we
pump is
suck
turned
blood
on,
from the left
providing
ventricle
support to the heart
and
while
pump
monitoring the
into
pumping
the
activity.
aorta.
The impella pump mimics the natural pathway of blood flow
This
from
is
the
an
heart to the
advanced
ascending
technique,
aorta,
of course,
increasing blood
with a
pressure
very high
while
cost,
unloading the
around
heart
about
and providing more blood
$20,000.
supply to vital
However,
organs
currently,
such as the
there's
brain
still
and
not enough
kidneys.
evidence
A
to prove
protected
that
PCI
impeller
procedure with
improves short-term
impella could
mortality
lead to
rate
less days in
in
the
comparison
hospital,
with
fewer repeat
IABB.
procedures.
Similarly, tandem heart is also an advanced technique with a relatively high cost, possibly up to $30,000. However, there are some promise evidence despite needing further research. The advantage of over ECMO is that it does not overload the left heart in comparison with VA ECMO. So we move on to the next section, some updates on CRT and catheter technique. Blood filtration with CO2 removal. This means XCO2 is a new technique under development applied as a sandwich measure in situation of refractory hypercapnic respiratory failure. However, there is still not enough evidence to show improved mortality rate. The cytokine absorption blood filtration has a new option, CytoSharp, with some new absorption techniques. Recently, there is a CytoSharp filter which can be considered for use in septic shock patients. The total cost is quite high, around 65 million Vietnam dong, but still need more evidence. It should be a rescue therapy in refractory septic shock. BICC lines are not a new technique, but they are increasingly showing many advantages in terms of safety and duration of use. Central venous catheters are prone to risk and have a short-term use, while BICC lines can be used for a longer period. We're moving on to the next section, point of care ultrasound focus. With the increasingly compact development of ultrasound devices, focus emerged and began to develop, especially in the past 2 decades. Focus has developed rapidly. Ultrasound machines for focus are considered life-saving device with many outstanding benefits in diagnostic and treatment. Here is the history of focus. ACEP released its first focus guideline in 2001, updated with 5 more areas in 2009 here, and expand further in 2023. During the COVID era, focus had been widely used. Ultrasound machines for focus play a vital role with many notable benefits in diagnosis and treatment. They can examine multiple organs simultaneously, assisting in various issues like respiratory distress, shock, difficulty breathing, chest pain, cardiac arrest, and abdominal pain. Especially for ECMO patients, focus support is crucial at every stage, from preparation to procedure, monitoring and management, and any abnormality thereafter. This is an example of focus in pre-ECMO procedure assessment. We can calculate LVOT, VTI, and then stroke volume. Here is the example of how we calculate the left ventricular EF by Simpson method. This is an example of focus in guiding vascular approach. We can see the needle from the skin into the vascular to make the patient more safety. This is an example of focus in continuous monitoring and reassessment. In this case, we have a patient with pericardial effusion. Focus training in medicine is more early. Now the medical student is training about focus in their school. Focus training is wider. This means our medical provider is talk about focus, even that about nurse. The final part of this presentation is AR in ICU. Artificial intelligence is a hot topic now, and in ICU it's not an exception. We have 2 models of AI in the ICU, predictive AI and actional AI. in predictive AI, the AI will take the information, then they will give us the thing like be aware approaching sepsis in this patient. But in the future, example AI, AI can give the information and give the conclusion and guide us what should we do. For example, we give the patient more 100 milliliter of fluid over the next 4-hour period. So in conclusion, ICU patients have a high mortality rate, so ICU doctor must stay updated. Some important topics from 2023 to 2024 that new ARDS criteria and management, cardiogenic shock, sky classification A, B, C, D, E, advancement in CRT and catheter technique. The era of focus has arrived and future of AI in the ICU. I have some suggestions for our ICU department. We should develop ECMO technique, develop focus, start to do BICC line, develop CRT, prepare for some new technique, tandem heart impeller, and prepare for era of AI. Thank you for your attending.